Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to SLP Learning Series, a podcast series presented by SpeechTherapyPD.com. The SLP Learning Series explores various topics of speech-language pathology. Each season dives deeper into a topic with a different host and guests who are leaders in the field. Some topics include stuttering, AAC, sports concussion, teletherapy, ethics, and more. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. Now, come along with us as we look closer into the many topics of speech-language pathology.
Hello, welcome to Making Sense of Selective Eating, Understanding the Psychosocial Domain, featuring Dr. William Sharp. My name is Maddie Metcalf, and I'm a speech-language pathologist with an interest and passion for pediatric feeding disorders. I'll be your host for this SpeechTherapyPD.com mini-series. Today's course is 1 hour and offered for 0.1 ASHA CEUs. If you're part of the ASHA registry and want your CEUs reported, you must have your ASHA number and address in your SpeechTherapyPD.com profile. Please allow 1 to 2 months from the completion date for your CEU to be reflected on your ASHA transcript. Now, without further delay, I would love to welcome Dr. William Sharp. William Sharp, PhD, is a clinical psychologist and professor in the Department of Pediatrics at Emory University School of Medicine. He is also director of Children's Healthcare of Atlanta's multidisciplinary feeding program. In this role, Dr. Sharp leads a team of professionals that include psychologists, physicians, speech-language pathologists, and dietitians who evaluate and treat children with pediatric feeding disorder and avoidant-restrictive food intake disorder, or ARFID. His research interests focus on identifying the cause, consequences, and treatment of chronic food refusal in pediatric populations. His most recent work involves developing and evaluating a training curriculum for therapists to deliver a manual-based intervention for food selectivity or extremely narrow diet in children with ARFID. Hi, Dr. Sharp. How are you doing tonight?
All right. How are you?
I'm doing good. Thank you so much for coming on the podcast tonight.
Yeah, I appreciate you having me.
Yeah, so the last couple of weeks, we've gotten to hear about just kind of an overview with Stephanie Cohen about what PFD is. We've talked with Lily Gullion. She's an occupational therapist, and she told us about how we can work with PFDs in the schools. We talked with Raquel Durbin about the nutritional domain. And last week, we had Dr. Praveen Godet on talking about that medical domain and GI. So this week, we are so eager to dive into that psychosocial domain and learn more about that.
Great. Yeah, let's get into it.
All right. So can you provide an overview of the psychosocial domain of PFD and what all it entails?
Yeah, so when they developed the psychosocial domain for PFD, they were using the World Health Organization. I believe Praveen probably spoke about the framework they used. And that looks beyond just avoiding and restricting food intake. It looks at the impact that it has on the family. It looks at the impact that it has on the parent-child relationship. So not only are we looking at the child's food restriction and avoidance, we're looking at the broader impact on the family and in the family unit. And I believe there's one more, and I'm forgetting it, but if it comes back to me, I'll remember what the fourth one is.
Can you dive into a little bit more about how that feeding relation or a child's feeding difficulties can impact that relationship with like their parents or their families?
Yeah. So one of the things that a major job of a parent when you have young children especially is to make sure your child's growing and thriving. So, when you go to the pediatrician, when you have very young children, one of the main things you do at the pediatrician visits is you get a weight check. They tell you where you're plotting your child. They tell you how well your child's growing. And if your child's not thriving and falling off the growth chart, that can really impact the parent, cause a lot of stress, cause a lot of angst related to and concern about their child's growth. There's also the case where if your child's really narrow with what they're eating, but they're growing fine, and you're saying, I have concerns about my child's diet, the pediatrician might be blowing you off or basically not seeing the level of concern that the parent has, because there's a mismatch between the data point they're looking at in terms of the growth chart and what the parents reported. Either way, when a child is rejecting food and having a lot of problems during meals, it can be very stressful for the parent, because they're wanting their child to do well and to be successful during meals, and it makes them feel like they're not successful because of the rejection and the lack of success with feeding their child.
Yeah, I didn't realize how touchy of a subject that would be, working with feeding disorders, until I kind of got in it. And it's always such a, I don't know, it's, even though I'm a speech pathologist and I am not a psychologist or a counselor or anywhere in that, domain, you have to look at them as a person and really take that into consideration. And one thing that I tell my students whenever they're with me, I'm like, we have to be so mindful of where that parent is coming from, because right now they have their child. And as a parent, your number one job is to nourish your child and keep them alive.
Yep.
And they're having a hard time with that right now.
There's also a history of blaming parents. Things aren't going well with their kids, dating all the way back to when autism was blamed on refrigerator mothers. I think the parents take a lot of the brunt when things are not going well, when it's actually, PFD is a diagnosis that now exists in the ICD-10 here in the United States. And then RFID is a psychiatric diagnosis that is in the DSM-5. And so these are actually disorders that is not the fault of the parent. Now, parents can inadvertently shape some of the problem behaviors they're seeing, because rightly so, it can be confusing when your child's not eating, and you might try a lot of different things and do some things that actually make it worse, but that's not intentional.
Right. Do you ever feel like a parent's own relationship with food or diet culture can impact their relationship? Like, can that also impact the feeding relationship?
We think that RFID, avoidant-restrictive food intake disorder, we think it might have a genetic tie. We think, PFD is a little different, because PFD is a broader term that encompasses those 4 domains. So, with the medical and the nutrition and the skill-based, a lot of those conditions also have underlying medical or organic issues that go along with it, right? So you wouldn't really see prematurity necessarily being passed down from generation to generation necessarily, but you could see heightened sensory sensitivity passed down. You could see GI issues passed down. I've had parents, I literally had a dad in my clinic who had his feeding tube removed about a year before his child started treatment in our program. And he said, I never liked food, never a big thing. I used my tube. And he ended up getting married, and his wife said, I'd like you to start eating with us. And I'd like you to eat at our wedding night. So he was motivated as an adult to get off his feeding tube, and he had a child with a feeding disorder as well.
Wow, that is so interesting. I didn't realize that psychosocial piece could also be genetic and passed down. So that is so interesting to know.
Yeah, one of the things we do in our clinic is we actually ask during the evaluation, what was mom's relationship with food like, and what is dad's relationship with food like? And we get a lot of positive hits on, I was always a picky eater. I never really, food was never really my jam. I didn't really necessarily enjoy eating. So we do see, and it's not every case, but for a lot of the families, we are seeing that. And then you mentioned cultural. You throw in the fact that a lot of times you might have dietary restrictions as part of the family diet. That can exacerbate if you're a selective eater to begin with, and then you're putting cultural parameters on an already narrow diet, it can make things inadvertently worse. So yeah, there's layers to that family dynamic in the diet.
So can you dive into a little bit about first off, is it at Children's Hospital in Atlanta that you lead the feeding team?
So it's Children's Healthcare of Atlanta, and we have 3 locations. We have we have a clinic in the autism center, because we do know that individuals with autism have a high rate food selectivity, particularly like eating a narrow diet. And then we have a clinic in the Center for Advanced Pediatrics at the main campus. It's about to be the main campus. And that program is really built for medically complex kids. We know that, medical complexities can really drive feeding problems. And then we do have a 3rd location that's in one of our suburban areas to try to serve. Metro Atlanta is really big, so we try to spread out a little bit. And we have about 144 team members that we have in our clinic that are geared toward helping families and children with pediatric feeding disorder and ARFID.
Oh, wow. That is so awesome, especially because you guys are kind of so spread out and interdisciplinary and are able to just help such a large area of kiddos. That's awesome. So what is your role as a psychologist on those feeding teams?
Yeah, so in our program, and it varies, what psychologists do on teams, but in our program, the psychologist is responsible for figuring out how to help the child reestablish a positive relationship with food. So, we view a lot of these children who are not eating, once they're medically cleared and we figured out they're not in pain or discomfort. Our view is that food avoidance that's chronic is a conditioned or a learning process. So what the child learns is that, this previously painful or uncomfortable eating situation, the way to avoid it is to, if I can't communicate, I don't want to do it, I'll cry, I'll push away the food. I might even get out, leave the table if I can. But basically, I'll do anything to avoid pain or discomfort along the GI tract. And that food refusal eventually teaches, the learning process comes about because the food eventually gets removed and the parent ends the meal, because the parents are also learning on their end that the way to get their child to stop having problem behaviors or crying or screaming is to remove the food and end the meal. So parents learn the way to get crying to go away is to remove the food. Children learn the way to get the food to go away is to get really upset. And so by the time they get to us, there's really this maladaptive relationship. Children, when they're put into a mealtime situation, they immediately get really distressed, and parents are cycling through a bunch of different things to try to coax and prompt their child to eat. Neither of these things are very functional in terms of helping establish a developmentally and positive relationship with food. So the psychologist's job is to use behavioral intervention, cognitive behavioral if you're older, as a way to teach the child, one, food doesn't hurt you and it can be something enjoyable. And then after we've really taught the child food won't hurt you, our job is to empower the parents to be able to take this treatment approach and adopt it into the home setting.
One thing that's just come up in every single episode is that while yes, we're working with the children, a crucial piece of feeding therapy is also coaching and empowering the parents. And so I just love kind of hearing you hit on that again this week, because it's just been a very common theme, and it's one that I found to be so important in my practice. Because if I can feed your kid, that's great. But what really matters is that you can go home and you can feed your kid.
Right. I mean, the goal of parent training is really paramount to our process. We are not a drop-off program. So I didn't describe our levels of care, but at the core of our program is a Monday through Friday. So Monday through Friday, 4 meals a day. So you come in, you start at 9, you have a 9 o'clock, a 10:30, a noon, and then an afternoon meal. And you're there the whole day for up to 10 to 12 weeks. And that program is really designed for the most severe kids, the kids who are on G-tubes who don't eat by mouth, the kids who might only have 2 to 3 foods in their diet, the really intense kids. And the goal of that intervention is to give us enough therapeutic time to help the child get from, zero oral intake to hopefully partial to full wean from their feeding tube or, really narrow diet. But the parents they're required to be there the whole time, which is a huge sacrifice. But they watch every session. We have observation windows where they'll watch the treatment, and then they'll participate as soon as we know it's going to work.
Okay. That would be really neat to partake in, but also seems like a really intense process for the child and the family, and quite a big commitment. That's, if they're having to take off work and that sort of thing. Although I do have one patient right now where their feeding is, they're so worried about their little one's feeding that mom has to stay home because they're like, I don't think I could send him to daycare. So they would have that.
Yeah, the way we sell it is that if we can transform your child's relationship with food in 2.5 months, then it's not like you're not going to have to worry about it again, but you're going to get over a major barrier. And what's really cool about the intensive program is we have a few studies that have come out where we've said what happens at the end of treatment. So our goal, let's just take kids on feeding tubes, for instance. Our goal is not to push volume. Once again, we're really about that positive relationship with food. Our goal is to teach the child that food is something that can be enjoyed. So when we looked at our outcomes for 81 kids on feeding tubes that saw us in a period of time, we found that only 32% of them weaned fully from their tube after 8 weeks of treatment. So about 32. But we looked a year later and we said, what happened to these kids a year later? And that 32 jumps to 71. So we have a more than
Wow.
doubling. And what's happening is the parents are doing it themselves. And what's really cool, we partner with Feeding Matters, the national parent organization
Mhm.
or the advocacy organization. We partner with Feeding Matters, and we're doing a 5 to 10 year outcome study where we're going to these 81 families saying, what happened to you as you grew up? And so we're looking at kids that are 5 to 10 years out from treatment, and we're about to tell a story about what was the journey after they left us after a year.
Oh my gosh, that is going to be such a cool article. I can't wait to read that. That'll be so interesting to see like where those families ended up following treatment.
Yeah, so we're excited about that. I
That's
just
going to be
looked at the data
awesome.
this morning, so
Oh, and then it'll also be really cool just to kind of see, like, from a treatment perspective, like what is going to be effective in these families. And so, I mean, that's like a very specific intensive approach, but, you know, laying the groundwork for what might be a good treatment approach.
yeah, we're asking them questions, and I was looking at the survey this morning, and parents helped develop this line of research. So it was the parents coming to Feeding Matters saying, we need to know what works and what happens to individuals who go through treatment in the long run. And one of the questions we ask is, how is your child's relationship with food now? Is it good? Is it neutral? Or is it bad? And I remember looking at data this morning, and the majority of parents report their relationship is a very positive relationship at 5 to 10 years out. So that's neat to know.
Oh my gosh, that kind of gave me chills. That is so awesome. I also think it's really cool that whenever they or at that 8 week point, only 31 or 32% were weaned, but then 71% after that full year. And so it really just goes to show like the power of one, laying the frameworks and the foundation for a positive relationship with feeding, but also that parent coaching, because that's like a huge jump following. Is that's over half that, or it doubled
It
after they
doubled.
like left, which
Yeah,
is awesome.
the article's really neat if folks are interested in looking at it. We actually had this table that we showed how many kids gained and then how many kids lost. And so we had two individuals go from full wean back to their feeding tube, but then we had like a huge swath move from partial wean to full wean. So it was a really neat kind of change to see happen.
We are research lovers here at Speech Therapy PD. Do you know the title of your article?
I will give it to you to give in the cliff notes. I don't
Okay,
have
cool.
I don't this one was like successful evaluation of factors related to tube weaning or something like that. But
Okay,
we can put it in the show notes afterwards. I can give you the bibliography.
perfect. Would love that. Okay. So, can you talk a little bit? So, I know that for a treatment approach is going to be different for every single kiddo, but can you talk a little bit, or would you feel comfortable sharing a little bit about what that treatment approach looks like from like that psychologist perspective?
Sure. We always start with a home baseline. So we ask the parents, show us what it's like to try to feed your child. That's fairly standard in our clinic. And the goal of that is to really figure out, is the kid eating anything? Like, what is the child's current relationship with food? And then we want to know what the parents are trying and may or may not be successful with. And so after that home baseline, for some parents, we start working with them immediately. And we say, here are some skills that we really think you should work on with, if the child eats anything, here are some things that you should work on with preferred foods the child likes. If the child's a complete food refusal kid and they're not eating anything, then we're going to start from ground zero. And we're really going to start with just systematic exposure, where we're gradually introducing food in a very, very slow and gradual manner so that the child gains confidence, gains experience, and really we try to disarm the child. They're so used to, in a lot of our home baselines, when you look at when we say, show us what you're trying to do, the most common thing that a parent will do is they'll pull out a bowl of, let's just say, yogurt. They'll pull out a bowl of yogurt. They'll take a giant spoon, fill up the spoon, and try to present it to their child as if their child eats, like as if they're like a great eater. And so the first thing we do is we say, we understand you don't like food and you're not an eater. So we recognize that the child doesn't like food. And we then take the perspective of, and therefore we have to go really slow, go very small, and build on success.
Gotcha. Whenever you're presenting those foods, are you using kind of like sitting at a table, here's a bowl, I'm going to eat this yogurt, or do you do it more of like a play-based kind of context?
So it depends. We're not a kiss, lick, touch food type of approach unless you won't kiss, lick, and touch it. So what I mean by that is and we're not we meet the child where they are. So I'll give you an example. I have a 3-year-old with us now, and he doesn't separate from his mom. If you try to get him to go for mom, and this is before he came to feeding therapy, he's not going to preschool, he's not going to relative's house, he's not having any separation.
Oh.
We spent the first 2 weeks of intervention getting him comfortable to go to a room with therapists and play with them in the room. And then we transitioned him into a chair and got him comfortable with the chair. And so I looked at mom and I said, this is in week 4, and they're staying a little bit longer because he's got a very interesting profile. But I said to mom, we've only been doing this for 2 weeks. And she said, but we've been here for 4 weeks. I said, yes, but we only started feeding 2 weeks ago because we spent the first 2 weeks just getting him comfortable with being alone with us in the room. And for him, we're focused on transitioning from a certain type of dependence on formula to actually consuming food by mouth. And so that's kind of our goal for him. And we're at a different spot where we've got him in the chair, and we involve toys if we need to. We involve toys either to make it fun or to motivate. And so by make it fun, it means enriching it. Motivate means if you do this, you'll get that.
Gotcha. So how can the psychosocial domain impact our eating choices?
Well, I mean, you could have zero intake if you're a complete, if you have, let me go back and give it the buckets. So I look at the buckets of kids, and ARFID has different buckets that they put them in. ARFID's got the 4 manifestations, which is you're underweight, so you don't eat enough food. It's got your nutritional deficiency, so you don't eat enough variety, but you might eat enough volume. And then ARFID, the third part of ARFID is really the dependence on enteral feeding or oral formula supplementation. And then the fourth part of ARFID is severe psychosocial dysfunction. So the first 3 make sense. I'm not eating enough volume. I don't eat enough variety. I don't eat it all, right? The fourth, I think, to your question is really that psychosocial domain that is in ARFID. And I used to not be a big fan of the psychosocial domain, and that seems weird coming from a psychologist, but what I meant by that is it's kind of ambiguous. It's not something you can measure. Until I started seeing more kids like that I'll use food allergy as an example. We started seeing kids with food allergy, and we partnered here in Atlanta with the Food Allergy Center. My friend Brian Vickery runs that center. He's a great doctor that studies peanut allergy and other immunology. Anyway, you get the idea. Immune system based feeding problems. And what we were learning was we were seeing kids who their weight was fine, they ate enough variety, they weren't on a feeding tube, but they would not eat at school, they wouldn't leave the house and eat, they couldn't go to restaurants because they were petrified of having an anaphylactic experience because they'd had one traumatic experience with food allergy. And so they go to school all day, they'd come home and they'd start eating at 3, they eat, their meals at home, and it had to be prepared in a certain way, and they had like safety concerns. And what we started learning is, wow, this can be a huge issue. It started as a medical issue, but it's no longer just food allergy. It's something beyond that. And the families really adapted their life to this child who basically goes hungry at school for 7, 8 hours a day. So that's just one example of kind of how this can be a broader impact that you wouldn't think about if you didn't see enough of these cases.
Do you think it's very common that ARFID develops out of an underlying medical or feeding skill deficit?
Yeah, so we're a little plug. We're going to have a summit later on this month through Feeding Matters to have this conversation, because I really think there's subtypes of ARFID. And in what we learned, so when ARFID came out as a diagnosis, it used to be feeding disorder of infancy and early childhood. You couldn't be diagnosed with that feeding disorder unless if you were 6 years or younger. You had to have it occur before then. But with ARFID, it opened it up to be a lifespan condition. So you can be diagnosed with ARFID in adolescence, as an adult. So I really think what we have is subsets of ARFID. I think some kids, adolescents, older kids who develop ARFID later on had shown risk factors when they were younger. They might have been very narrow with their diet, been very picky. And therefore then they have some type of psychiatric, usually it's anxiety type of issue around adolescence, or late childhood, where they really go down a rabbit hole and restrict their diet. But then other kids with ARFID are the kids that I'm used to seeing throughout my early career, which were the 2, 3, 4-year-olds who are medically complex, who have never had a positive relationship with food. So I think to answer your question, I think some individuals with ARFID are PFD kids that grew up,
Hmm.
And never really, and the medical got solved for, the nutrition might have gotten patched up, the skill developed, but they still actively avoided food. And then I think there's some individuals with ARFID that were normal eaters. By normal, I'm saying they learned how to chew. They never had a feeding tube. They never had, significant restriction, although they might have not had the most positive relationship with food. But then they might have had some event, and they usually have a triggering event. They'll say that choking episode, but usually if you really get down to it, the child's very anxious or very perfectionistic, and that something occurs that makes them really stop eating for whatever reason.
Mm-hmm. What do you think about like a 2-year-old getting diagnosed with ARFID?
So my colleagues and I don't necessarily agree about this. But what I tell them to do is go read the diagnosis of the DSM. So the DSM is actually where the diagnosis lives. And it actually says verbatim in the DSM, ARFID typically first arises during infancy. It uses the word infancy repeatedly. So to your question, infancy's 2 or younger. So I say ARFID can occur at 2 or younger, and I treat kids 2 or younger. Now, my eating disorder colleagues would say that ARFID needs to be a cognitive component. That kids need to be, it's a psychiatric condition. But there's tons of things in DSM that are young developmental conditions that occur during early childhood. Disruptive behavior disorder is another one. Kids develop sleep problems early on, toileting. So I view feeding or ARFID in the same bucket as those conditions.
Okay. Makes sense. You just have my wheels turning, Dr. Sharp.
Well, I think it's just a different lens to look through it. I mean, I spent more time because I liked ARFID when it came out for a few reasons. One, the previous diagnosis of infancy and early childhood that was in DSM-4, you had to be underweight. So I could get kids on a feeding tube coming to me for treatment, and they wouldn't meet diagnostic criteria for that disorder because their weight was fine. So I'd be like, okay, you don't eat, but you're using the tube correctly, and I can't work with you. Or you could be you could be a selective eater and you could be obese, but you only eat 3 foods and you've got rickets or scurvy. And I couldn't bill for that because that wasn't, so I think ARFID's beautiful in that sense. But what I learned about ARFID as I got deeper into it and I started talking to more people across the aisle of the eating disorder and the feeding disorder world, because I was a bit confused why they did PFD until now I understand PFD too. But I felt like they took our diagnosis and they kidnapped it and they made it something else. And so when you go read about ARFID in the eating disorders literature, they'll say it's new. We don't know anything about it. It's these older kids. Do they have anorexia? How are they similar to anorexia? I was like, wait a minute. It used to be called feeding disorder of infancy and early childhood. Why are you studying it in eating disorders population? So I think it's because we do know that kids with ARFID were showing up at the eating disorder clinics and they were confused by them and they wanted a diagnostic home for them. So that's how ARFID really got championed by the eating disorders community.
When did the ARFID diagnosis come out?
2013.
Okay. All of this is just so new because we got the PFD code in 2019. 2019.
So the reason I said I wasn't a fan of the PFD diagnosis at first was I was like, why do you need that? We got ARFID now. ARFID's perfect. It was perfect for me, right? Because I can now see all the kids that I needed to with underweight. But what I think PFD does so beautifully is it highlights the need to medically screen kids that aren't eating. It highlights the need to look at feeding skill, and make sure you're checking off the box of swallow safety and underlying skill deficits. And then there's significant overlap between ARFID, between the psychosocial domain and the nutrition domain. They're basically verbatim, except that PFD does include the holistic approach to looking at the family dynamic and looking at the broader impact on the family and the family unit.
It sounds like you were already doing that a little bit though with your ARFID diagnosis as well though.
Right, but the manual is so specific, it didn't broaden it that way. It would say how does it impact the family? But it didn't, with PFD, it explicitly says this is diagnostic.
What does your working relationship look like with SLPs usually?
So we've got a group of SLPs in the program so there's really, I'd say 3 relationships we have. One is we employ them, and in our program, they're not necessarily consultative in nature, but their job is to make sure the child is safe to eat. And if they're safe to eat, that it either means they can begin the treatment because they're not aspirating and they're not currently having any type of safety issues. Or if we're trying to advance texture, they might be telling us like, hey, I wouldn't jump to this texture right now because that would be a choking hazard. There'd be some safety concerns there. They're also, sometimes we be prepping a child for a swallow study. So if a child's never been able to participate in a swallow study, we'll bring them in, we'll establish some level of intake, and then our SLP team will coordinate with our internal swallows, the swallow team that do the swallow studies. So that's the second relationship, is we have a relationship with the hospital-based SLPs who do swallow studies and evaluate swallow safety. And we send a lot of kids, they either send them to us to get prepped, or we send them to them once we prep them to see if they're safe to swallow. And then the third relationship we have is we have a good relationship with I'd like to say we have good, with our community-based providers who are, we know that PFD is such an unmet need in the community. We know the majority of people who are providing care in the community are speech language pathologists and occupational therapists. And we take referrals from those providers when they need more intensive treatment. And then we send them back to those providers once we've got it to a good point, and they continue working with the parent on whatever remaining things that need to be worked on.
Do you ever collaborate with the outpatient LPs or OTs to kind of let them know what you did in your...
Oh, definitely.
Okay.
Yeah, we send them, sometimes we tell them, please come to our clinic and watch. We sometimes tell them, this is what we want you to work on. This is what because we still follow our kids when they leave us. Like, we see them easy, like every other week with a psychologist, just to make sure the parents are well supported, they know what they're doing, and the kids are continuing to make progress. But at the same time, I'd rather not work on texture advancement. I'd rather somebody on the skill domain work on that. I'd rather not work on some of the other skill-based components, because that doesn't fall under the psychosocial pillar.
What are some red flags that should alert an SLP that they should probably refer their kiddo to a psychologist?
They're not making progress. And I think it depends on what, one of the things we wrestle with when we talk. So we have an internal work group where we talk amongst all the SLPs in our system, and they're like, what do you mean by progress? And we need to define that. So I think progress to me means, are you making within 3 months? I think some insurance programs say 2 months, but are you making meaningful changes in the child's diet within a reasonable time frame? And taking one bite of a new food, a session is not meaningful to me. It might be a good starting place if you were, session 1, but if you're 2 months into treatment and you've got like one food on board, or you're still working on a few foods or you're not weaning by that point, I think you would want a more intense approach. And let me give a little bit of a background, because I know some intensive programs have bad reputations, and rightly so. I think some of the techniques that have been used at some of these programs historically have not been very well thought of. It's not child-centered. It's not responsive to the child. And I think that's where we came from. Me as a champion for intensive intervention, I'm more of a champion about the environment itself versus what actually had occurred during treatment. So let me sell you on, you can debate me on this, but let me tell you what I think the environment does. I like the environment because it has a multidisciplinary team. It's got GI, it's got nutrition, it's got SLP, it's got psych, all under the same roof, right? It's giving you a dose of treatment that you can't get. So when you do weekly therapy, you come one time a week for, let's say, an hour. I'm doing an entire month of treatment in one day. I know it doesn't really equate to that, but you're getting 4 sessions a day, where it would take you a month to get those 4 sessions. Right. And within 1 week, you've done 5 months of treatment. I'm being a little facetious, but you get the idea of that dose, right? And then you're involving the parent with every step of the way, and you're showing them how to do it in a way you can't do in that outpatient setting. So that's my plug for the intensive model. But I know there's not enough capacity to meet the unmet need in the community. And my intensive program is the largest in the country. I know that because we did a study recently. We have 32 slots at a time, where 32 kids are enrolled in the program at the 3 locations. That is 3 times this, or at least almost 3 times the size of any other program in the United States. So we don't have enough capacity. So I'll be clear on that. But I do think, although there were some things that happened in these intensive programs in the past, I do think the things I just mentioned hold benefit for many families.
How does responsive feeding, like a responsive feeding framework, fit into the intensive paradigm?
Yeah. So, it's interesting you say that. My colleague, Colleen Lukens, I'll plug her a little bit at CHOP. She always says, Will, stop saying that because it's not true. But it is true for the most part. In our program at Children's, and I think this is true for many other programs, we don't want kids to be upset, right? crying and screaming when food is presented is not what anybody wants. Like, that is not what I want. That's not what you would want as a therapist. That's not what parents want. And so our job is to somehow get the child to make contact with food so that they are not screaming and crying. So what a colleague gets mad at me for saying is, I usually say, and so when a child, we don't want children crying. We stop when children are crying. She's like, do you really? And I'm like, yes, but that doesn't mean we stop intervention. We pause what we're doing when a child's getting distressed, and we look at the child and say, is there another avenue we can go about trying to help you develop a more positive relationship with food? And then we go down that avenue. So treatment doesn't stop, but we do pause intervention when a child is not responding in a positive manner to what we're trying to accomplish. I think in the past, and maybe even currently in some programs, they would view it as an extinction burst. You've got to work through the extinction burst because you've got to get through the problem behavior. No, you don't. Extinction bursts may be necessary in very rare cases where children are so resistant to making contact with food that you have to have a little bit of, there's going to be cases where children are going to be like uncomfortable with what you're asking them to do because it is a challenging thing for the child to go through.
Right. But
it doesn't mean it should be a torture chamber. And I think those are distinctions. So,
right.
But I do think they're pendulums. We at Feeding Matters, because I'm on the research task force at Feeding Matters, we talk a lot about camps. And I think there's a camp now that says, we're the responsive feeding people, and we have a white paper, and we shouldn't do X, Y, and Z. You should never. And I actually read their white paper. I like it a lot. But you also shouldn't reject 40 years of research that suggests that behavioral intervention and cognitive behavioral intervention is a very successful way for structuring meals if you do it in a responsive, thoughtful way.
I definitely feel that. So I graduated in 2020 and have just dove straight into the feeding world. And that's definitely something that one of the reasons that I decided to do this podcast is because there's such a broad spectrum of ways to approach feeding therapy. And I resonate with so much of what the responsive feeding camp says, but then sometimes whenever I'm like really leaning into the responsive feeding camp, it's like, okay, but I feel like there needs to be a little bit more, push with some of these kids sometimes. And so, because, learning new skills is hard and we have to challenge ourselves sometimes. And
yeah, keep on going. But I've got a comment after this, but go ahead.
But yeah, so just kind of finding where I fit in with that kind of on that spectrum and what's going to be the most beneficial for my kids. And it's been really enlightening talking to you tonight and kind of hearing more about that cognitive behavioral background and where that, just kind of that pushing through sometimes can be beneficial because it was shown to be beneficial in your tube feeding study that you did.
Well, and one of the things my colleagues, I've got three kind of caveats to what you just said, because I think they're all good points. One is feeding somebody by feeding tube is not necessarily any better. That's not voluntary eating either. It is an artificial way to get your needs, right?
Yeah.
I have a little guy right now that we're seeing, 3 years old, dependent on a certain type of milk that's not going to be available for very much longer. So he's actually going to lose a source of intake, and he can drink. We know he can. But he's the kid I was describing earlier that has trouble separating. So the way we did this is we present him with very reasonable, it's a new milk. He's never made contact with it. We present very small amounts of it, ask him to take a drink, and then after that, he can go back and see mom. And once he learns that, I get to see mom after I take my drink. And so then we're going to gradually fade up the volume of that until we can wean him from his milk. Now, if we would have said, hey, man, it's okay if you don't want to drink this, he's going to end up in the hospital, either in the hospital for malnutrition or in the hospital to get a feeding tube. So that's the second story I'll tell. There was this great story at this feeding panel I was at, and the speaker was from the Florida program in Florida, and she likened it to her son getting stitches. So this kid, in this case, needs treatment. He needs to get stitches, and that's the analogy here for the kid that needs to transition to a new formula. She talked about two different experiences that her son had getting stitches. Apparently, he needs stitches a lot. I don't know exactly what's going on with him, but she described one time he went to the hospital to get stitches, and they asked him, hey, do you like stickers? Do you like toys? Would you like to have other things involved while we wait to figure out stitches? What color stitches do you want? How many stitches do you think you need? We could give you 8. We give you 10. He was heavily involved when he could be. He was participatory because he could be, and he didn't get upset as upset as you get when you're getting stitches. but he didn't have to be held down. He wasn't like, it wasn't this forced thing. She described then a second situation where he went to the hospital, get stitches. They didn't involve him at all. They brought him in, barely talked to him, gave him the stitches. He flips out, has to be held down, and everybody was traumatized by the situation, right? So I liken the first approach is how feeding should be done. Involve, adapt, and enrich as much as you can. And the latter example is what feeding should ever be.
I like how in that first example of what we want feeding to be, it kind of even fell on those like responsive feeding tenets of, he had some autonomy in getting to choose what options he wanted. Like, how many stitches do you want? 8's going to be fine, but 10 will be fine too. Which would you prefer?
Yeah.
He got to have like a little bit of like relationship with the providers that were there, and then competency. He had to do it. But
you got to do it. So it's interesting because my team's gotten so almost like the kid with the cup I was talking about earlier. They were letting him do all types of wacky stuff. I mean, not wacky, but they were trying to shape it up. Okay, just touch it to your lips. And he was like pouring he wasn't making any progress. So I went back down and said, guys, we know he can drink. We know he's capable of drinking from a cup. We just need to tell him, you do this and this happens, right? And so he's got to get his stitches. We'd enriched it enough. And by the end, his mom was in tears because, within this short period of time, he'd gone from I won't do this at all to I'm now taking my drink, swallowing it, I'm leaving and to see my mom. So it's a balance between being too slow or too. So I think if the field could take the approach of it's treatment. Treatment means you're doing something, and sometimes it's something the child's not going to want to do. And we shouldn't overwhelm the child or the family, but you got to have something that's, and something to me means you're eating, like it's going down your throat. There's some progress toward swallowing new foods and increasing the volume.
Right. I like that you shared a little bit more about that. Kind of like he gets a drink, he goes sees his mom. It wasn't like first day of therapy. We separated from mom. We put him in a chair. We said, you have to drink this 5 milliliters of milk, and then you can go see mom. There had been like, you'd already worked on establishing that rapport with the therapist to leave mom. You were doing like positive things. He'd been around the milk, had some positive experiences with the new cup and the new milk and all the things. And then you're like, okay, now it's time to up the ante a little bit. We really need him to drink the milk so we can start building on that skill.
He drank water. So not only did we not bring in milk first, we established that he drink water with a therapist in our chair out of the room. And then he got the if I do this, then I go to see mom. And then we went to formula.
So there was even like another little step that just was like, okay, we can do this. It felt like we are at a point where we could maybe challenge him a little bit more and work towards that feeding goal.
And he wasn't happy necessarily, like, oh, you're really going to make me do this, but he did it. And then he learned it didn't hurt me. He actually liked the taste, and he pretty much, so it's about helping the children make contact with food so they learn that it's actually, because like in this country, most kids are obese because they're eating too much food, because food is a primary reinforcer. So our goal as a treatment team is to teach kids, and we don't want them to become obese, but we do want them to realize that food is something to be enjoyed.
So we had a question. How would you recommend handling cases for school-age children that are refusing to eat during the school day despite eating food at home? And this kiddo is in regular education and not on an IEP.
I'd first ask what they're sending the school to begin with. Is it the school lunch? Is it home-based foods? If it's school lunch, I might plan for that. Especially if the child's selective, I might look at the menu and say, is there really anything the child can eat anyway? Because it might be unrealistic for them to go through the lunch line. I would then, as a therapist, practice the foods from the food list from the school. If the school lunch is the way to go, I would then focus on, like, we're going to work on these foods. We're going to have you practice in treatment actually eating the foods that are the school lunch, and then we're going to pick a day that you're going to go to school and actually order the foods and do that. If school lunch is not on the table and they send foods from home, then I would be making sure we're darn sure sending foods that we know the child really likes and is highly motivated to eat. So and then I would establish some type of a monitoring system with the teacher that's saying, like, did he eat it? Yes, no. And that there's a way to track how much food's eaten and how much variety is eaten. And then I might come up with a reward system either way. Like, I'm a big fan of some type of a reward system for success at school, so that it ties, like, you do this work at school and then you come home and you earn something.
And so this kiddo has access to both school and home food? And so, and he gets upset about 20 minutes prior to going to lunch. At times, the student gags and vomits prior to eating. Is this kiddo getting
Uh,
services outside of school for feeding? No,
So,
they're not.
so, so this kid sounds like an ARFID kid, like a
Mm,
kid who's he might be overwhelmed by the sensory nature of the cafeteria with all the sight smells of food. It could also be the kid's overwhelmed by the social nature of food. So I might recommend that the IEP, if there is an IEP, I don't remember if you said that, if that we conduct, the eating actually occurs somewhere separate and that they eat like in a private area that is separated from the cafeteria. And then if there's a social need after the kid eats, then you could send them to the cafeteria. Or you could incorporate the social by having a smaller group of peers eat with the child in a separate area. But I mean, the cafeteria, I don't know if you've been to a kid's cafeteria. They're loud, they're obnoxious, they're stressful. I wouldn't eat with my kids when they were little. I didn't have a good time. So like, I wouldn't expect an anxious eater to have a good time either.
Another good resource would be episode 2 of Making Sense of Selective Eating with Lily Gillian. We go into depth about feeding in the schools, accommodations that you can work for, which includes moving them to a smaller area, that sort of thing. But I also might refer out for additional speech services, get an evaluation, maybe an OT to see if there's sensory concerns or something like that to kind of help navigate that.
Yeah, I mean, if there's vomiting happening, before, that could be a lot of anxiety related to going.
Yeah.
I mean, I've had kids who also go to the mall, walk into a food court, and just smelling the food causes them to projectile vomit. So I think it's
Wow.
important to be looking at this as not just like it could be broader, to your point, than just a school issue. It could be a very kind of sign of ARFID and or PFD.
Mm-hmm. Now that is the PFD diagnosis, do you guys ensure that all kids get like that medical screening prior to getting the ARFID diagnosis?
Yep. So we highly recommend that any child who's not eating starts off and see here, let me get back. The problem with MDs, and Praveen, I apologize. I know Praveen well. He was on last week apparently. The problem with MDs is they don't take it, they're not as worried about things as we are. And I think that's because when you're a physician, the main outcome that you're trying to prevent is death, right? Like that's what you're trying to actually like keep patients alive. So sometimes, like I'll give you an example, they insert a feeding tube and they say, job done. I got to wait for the kid to eat. But we're like, hey, but how are you going to get him to get off the tube, right? So when I say that is we highly educate our provider group that we work with to say, this is weird. And it's weird because of this, right? Like, and we need you to be paying attention to X, Y, and Z. And so they'll be like, oh, I didn't know I should be considering a scope for EOE, or I didn't know that like you're concerned about potential food allergies, or I didn't. So, we go a little bit overboard because my GI doctor will say to me, you would scan for brain cancer before you would, if we can't tell you that there's an organic issue. So we're always wanting to understand what triggered the maladaptive relationship with food or the inappropriate relationship with food, so that we can feel good that we don't want to cause harm, right? You don't want to make it worse by doing behavioral intervention or any type of exposure therapy to a child who shouldn't be eating to begin with.
And anytime that I refer a patient out for a medical, in my referral, I write a very in-depth referral. I'm like, hi, I don't say hi, but I'm like, referring this patient for GI. We have all of these symptoms. Please please like rule out any GI disorders, including but not limited to delayed gastric emptying, EOE, and kind of list out a couple of things just to be like, I really want this to be a full workup, please.
Yeah. It's because they look at the growth chart.
Yep.
They're not as because they're looking for like major disease states, and I don't think that they're necessarily viewing a pediatric feeding disorder as a disease state.
Right. And it's so sad that that's the case. I'm so thankful that I have a really awesome PFD savvy GI in my area that has I think he's been here for like a year now, and he's been fabulous. But I know that hasn't been the case in our area because the number of patients that I have where the parents come in and they say, my child has never left their growth curve. They've always been like with the normal limits, but I'm so worried about their eating. They only eat this many foods. We have all of these like constipation, burping, reflux, like whatever going on. But because they were hitting those numbers and they were checking those boxes, the parents just got told, oh, well, they're just picky. They'll grow out of it. Or, well,
Right.
it's fine. Their weight's fine. That's all that matters. Just keep presenting food to them. So
Exactly.
I'm so hopeful that is, the PFD diagnosis gets, it's just around for a little bit longer, more research comes out and more awareness is gained, that hopefully we'll start seeing a shift in that. So I know that we've touched on this a lot throughout, but, and just like, is there a distinction between ARFID and like PFD selective eating that you can say, or is it really just kind of a complex, messy picture that you have to look at?
So that gets back to those buckets, that ARFID is really a heterogeneous diagnosis that involves lots of different relationships with food. The kid you described that's always been, a food selective kid, they're unique in many ways because they can chew food. They're usually self-feeding, so they can eat, which for kids on feeding tubes, that's amazing to be able to eat. Like, wow, right. you actually know how to chew and eat food. And so what they're normally doing is they're eating a very narrow range of foods. It tends to be a gravitation towards starches, fats, processed foods, and a rejection of fruits, vegetables, and healthy proteins. And the reason we think that's occurring is because nature makes variety and human processed foods make consistency. So a goldfish tastes like a goldfish unless they change the recipe, and then that throws the kid with food selectivity off. But the other point I always like to make when I'm talking about this is that food selectivity is not picky eating. And I know picky eating is a good way to get people to like wrap their head around food selectivity, but picky eating is a normal developmental process that occurs for every kid beginning around age 2 to age 6. What I think is happening with the ARFID picky selective eating kids is that they're not growing out of it. They go into it and they never come out because they have either a sensory profile or a lack of motivation related to eating, and they're stuck in this narrow range of foods. They're growing fine, so nobody's raising flags about it. But we've done one of the things we do clinically, and this is a standard of care in eating disorder clinics that I've learned, is we're doing increased bone scans where we're looking at the impact of a narrow diet on the child's actual bone development. And we know from like the anorexia and the bulimia research that's done in eating disorders programs that restricting diet can lead to poor bone growth. And we're finding that in our selective eaters as well.
That is pretty significant over a period of time.
Well,
and then
go ahead.
Oh, no, you're good. Go ahead.
I was going to say, we've also seen scurvy. Scurvy is a vitamin, we got our first case of scurvy about 10 years ago, and it was a kid with autism who only ate 5 foods and drank water. And we wrote a paper about it subsequently about like scurvy was being seen in multiple hospital systems across the country. And they treated each scurvy case as unique. They were like, hey, this kid shows up, he's not walking because apparently not walking is a sign of scurvy or one of the symptoms of scurvy. And they spend time, they admit the kid to the hospital, they're trying to figure out why doesn't he walk? They think it's neurological, they think it's this. And it turns out the kid eats no fruits, no vegetables, and has developed scurvy. And so I think going back to that medical overlooking the feeding issue, it is not usually until like week 2 of the admission in the hospital, they ask the family, what does he eat? And they're like, oh, only 3 foods. Like you could ask that to begin with and figure it out. But it's because scurvy is not something you think about in the modern world.
Wow. That is so interesting and so sad. So how much do you guys promote diet variety and expansion in your programs?
So, the typical, when you read this model of care, it's usually something between 12 to 16 foods, but we want foods from all food groups. If you've got healthy grains, if you have enough carbs already, we definitely want fruits and vegetables and healthy proteins are our 3 main areas we want to make sure we're on board. We want foods to be meaningful. We don't want them to be foods just because we don't want you working on different varieties of chicken nugget unless the child's so rigid that you have to start with working on variety of chicken nugget before you can get to a variety of something else. But we want it to be nutritionally meaningful is the most summation of our approach is that we typically add 16 foods within our treatment program by the time the child's done with us.
That is awesome. And they're consistently happily eating those 16 foods by the time that they leave.
Yes. Plus a nutritionally complete drink if we need to.
That is so neat. Again, I know this is really broad question and it'll vary based on the patient sitting in front of you, but what do you do with the kids that just don't have a desire to eat? They don't enjoy it. They're not interested.
Yeah.
They would rather not ever eat again.
So I'm gonna bring up my eating disorder colleagues. So they've done some really cool studies and they've shown that I'm gonna call them the ambivalent kids, the kids that just don't care about food. they
Mhm.
actually have a lower level. This is from the research here. They actually have a lower level of ghrelin, which is a hunger hormone that promotes hunger in satiety. And we know that lack of motivation is probably actually being biologically driven. So the way that we approach it is we treat it as food is your medicine. And so just like you got to take your insulin, just like you got to take if you have ARFID or PFD, and you got to eat. And
Mhm.
so we set it up like, I know it's not pleasant, but you got to do this routine on a consistent basis, unless you just want to be fit. Feeding tubes are a vehicle to meet your needs. Unless you are okay with feeding yourself via feeding tube, like I started off talking about the dad who got off the feeding tube because he was motivated, he
Right.
probably had the ambivalent ARFID, as I call it. But yeah, I mean, it's treating it as like you got to do it or you got to go through the medical intervention. And it could be that you say, you can get it from food, you can get it from formula, you could drink, Pediasure, you can get a feeding tube, but these are your options. And we lay it out on the table for the
Mhm.
ambivalent kid.
Can you spell the name of the hormone for us really quick?
Ghrelin. And I'm a horrible speller.
Oh, let me see if I can Google it.
I think it's Grelin. Ghrelin. But look up hunger hormone and you should be able to find ghrelin.
Yeah. So for people who are listening, it is Oh, wait. So sorry. Okay. I can't spell on top of the time. Grelin.
There was an H in there. Yep.
Yes. Sneaky H. Gotta love English. Man, so there might be like, once again, kind of falling in that medical domain, like a biological, physiological reason that these kids aren't wanting to eat that goes beyond just maybe being like, because my brain was kind of limited to like, oh, well, there must be a medical issue. And then if there's not, then it's just purely psychological because they've had a negative experience their whole life.
Yeah, and that's why I partnered with the eating disorders community, and I've joined I never thought I'd say I'm on the editorial board of the International Journal of Eating Disorders, because I said I don't treat eating disorders, but I'm on it now. They've really learned three things, and I'll highlight my colleague Ginny Thomas at Harvard, who really led this. But they found that ARFID, at least in older individuals, has three etiological drivers: the lack of the ambivalence driven by ghrelin, so that, like we talked about, so I'm ambivalent to food. I'm afraid of food, either from a traumatic event or some type of anxiety disorder or conditioned food avoidance, like I talked about earlier, or I have high sensory sensitivity to food. And those three variables can be overlapping, but they found almost every individual is one of these categories.
Oh, man. So interesting. And again, like this, we just got the ARFID diagnosis in 2013, PFD in 2019. Like, what more are we going to learn as we just kind of continue to like gain momentum? Because that's still pretty recent.
Yeah.
Wow. So for those kids, have you found any harm in treating it as that like prescription for these children, or like, does it damage their relationship with eating, or does it kind of put it in a more tolerable headspace for them?
The idea is tolerance. It also is about removing the conflict between the parent and the child. So oftentimes the parents are way putting stress on the kid to eat, and we try to normalize it through psychoeducation, being like, he probably has what I'm going to call ambivalent ARFID, because food just not his jam, like that. And I use the word jam twice, but not motivated to eat, doesn't really enjoy eating. And so we have to treat it like you got to do it. And so it's your medicine, and it's time for your medicine. And that's a different way to frame it than like, don't you like food? Let's get you to enjoy eating. Like that. It's not feasible for some kids.
Yeah. Oh, man. So interesting. Do you have any tips for therapists that might be in areas where they don't have a strong feeding psychologist in their area?
I don't have tips yet, but let me go back. I have tips. I think training's needed. We know more training's needed. We are working with Feeding Matters on education, the first thing we're working on. So you'll see some of that hopefully come down the line. Me personally, I'm working on a training curriculum that we hope to offer. We piloted it more. We're piloting it right now. It's geared toward community-based providers to be able to provide more robust treatments. It's not available yet, but like I said, we're piloting this summer to roll it out so that we can help more and more providers. That's still not the ultimate. I think what we learned from community providers is they're usually having to train themselves. So what I'd love to see is a more unified field less camp-based field. And I think to your point, when you're in the field doing it, none of these like camps necessarily make complete sense, right? Because you're doing it, you're like, this doesn't really feel exactly right. And so I think the piece of advice I give you is be eclectic and grab little pieces of what makes sense and make sure it feels good about what you're doing, and it's not a reaction to some other experience you've had, but make sure it's logical. I think responsiveness has some value. I think behavioral intervention has some value. I think SOS, as a branded treatment has some value, but none of them are, you should acknowledge the value of each one of them, and none of them are holistically appropriate for every child.
And one thing that I found is what I do with one child is going to be so amazing, and I'm going to be on my A game and feeling so good walking out of that session. And then I can turn around and I can do that exact same thing with another patient and it will blow up in my face. And so you just have to what I'm finding is you just have to kind of take bits and pieces from all the different trainings and approaches that you learn about and fit them together in the way that's going to be right for that patient sitting in front of you.
And then I think there should be a willingness to refer to an intensive program when you need to. Yeah. And we take kids from all over the country. We're working with the Ronald McDonald House here to build a Ronald McDonald's feeding aspect to their new program, where families stay and they have a feeding specific suite to be able to feed. I say all that. Wow. I can share another paper that shows you every program in the United States that we have a bunch of publications that we'll give out as part of this, but we do have a landscape paper that lists out every intensive program in the United States, because we worked with 2 organizations to figure out who's out there doing this and what do they offer.
Let's see. I'm gonna see if I could find it really quick.
It's like intensive feeding intervention, intensive.
Ooh. Oh, I have intensive multidisciplinary feeding intervention for high-risk infants, and then
that is, yeah, I see what you found.
Intensive multidisciplinary feeding intervention for patients with ARFID disorder associated with severe food selectivity. I don't think that's the...
Yeah. Treatment landscape. Let me type treatment.
To get a patient?
It's the article is called Intensive Multidisciplinary Day Programs in the United States, a report regarding the treatment landscape. Intensive Multidisciplinary Feeding Day Programs in the United States.
Got it. It is in the chat. If we have a patient on our caseload that we think would benefit from an intensive program, is there an application process that you go through?
We just take referrals, and then we had a family from New York recently. I sometimes will personally work with the family to say, because they're flying down here, they're going to live down here. It's a huge commitment. But what you'll see on the paper, and we have this great map in the paper, at least I think it's great, that Feeding Matters helped me with, is we show where these programs are located. They tend to be located in the eastern part of the United States. They tend to be clustered in the mid-Atlantic, but there are programs that are probably within 2-hour driving distance, at least in the Northeast for a lot of families. We're pretty much in the Southeast, except for Florida and Wilmington, North Carolina. But that's in the paper we described there needs to be more of these programs. There's not enough.
Oh man, how do you start a program like this?
It's not easy, and you need a lot of institutional investment, because it's expensive to have a multidisciplinary team all operating under the same roof.
Yeah. A dream, though. Wish we could have one of these in every state going. That would be so neat. Well, Dr. Sharp, I thank you so much for your time this evening. I'm so happy that we were able to have you on the podcast, because I learned so much from you this evening. You opened my mind a little bit more to the cognitive approach to therapy, and I am going to reach out to some psychologists in my area to see if I can find some good psychologists to bring on my feeding team here. It was just super great and eye-opening, and I loved learning about the psychologist role in the management of pediatric feeding disorder and ARFID. As a reminder, everybody tune into the Psych Summit that Feeding Matters is putting on. It's going to be so interesting. And yeah, do you have any final thoughts or closing words, Dr. Sharp?
No, I appreciate you having me.
Yeah, absolutely. Thank you again.
Thank you for joining us for today's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to reflect on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code SLPLearn20. Speechtherapypd.com is run by SLPs for SLPs. They've got the largest library of ASHA CE eligible courses out there, and they're adding fresh content every week. Remember, use the code SLPLearn20 to get $20 off access to over 1,000 courses for an entire year. Head over to speechtherapypd.com for more information and start earning CEs today. Thanks for tuning in to the SLP Learning Series. And don't forget, speechtherapypd.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us, and we'd love for you to drop us a quick review and hit that subscribe button.